Well, in order to stay on time, I'm going to get started. I was charged with putting together an update on what has happened in minimally invasive pancreatic resection since the state-of-the-art conference that was held 2 years ago at the IHPBA in Sao Paulo, Brazil. So I'm going to make a shameless plug here. I am the scientific program chair of the AHPBA for 2019, and I hope you will all come. So here's an overview, and for those of you who do not know me, I'm David Kooby from Atlanta at Emory. I'm going to provide an overview first of the state-of-the-art conference, just very short, the conference that was held in 2016. And then I'd sort of like to walk down the ideal framework of where minimally invasive pancreatic resection is. And for those of you who are not familiar with the ideal framework, I'll make that relevant to you. What we did not have 2 years ago were any results of randomized trials. As a matter of fact, the first was presented at that meeting after our conference. So we'll talk about what data we have, randomized data on distal pancreatectomy and Whipple, and then briefly mention what the next steps are going to be. So the minimally invasive pancreatic resection meeting was a full-day conference in Sao Paulo, Brazil at the start of the IHPBA meeting 2 years ago. It took 18 months to plan. There were 16 members in the organizing committee representing 10 nations. And it evolved from a consensus conference to more of a state-of-the-art conference because there really was a paucity of high-level data. And so we determined that we could use this as a spark to move the field forward and for future meetings. We had 450 attendees, 50 were faculty, which also included non-surgeons, and 400 registered faculty. Importantly, we kept this devoid of industry support so we could be devoid of conflict of interest as much as possible. This is a summary of how that day went. For those of you who were not there, we broke the day up into 6 modules. There was an introduction where we outlined what the day would be about. Claudio Bassi gave a very nice talk outlining what the key metrics in pancreatic resection and outcomes should be that we care about when we're going to compare 2 different ways of doing an operation, or maybe 3 or 4 different ways. We made a nice attempt at coming up with standardized terminology. Andre Montagnini took that role on from Sao Paulo, Brazil, and we did this by a Delphi process so that when you read a paper now and it talks about mini laparotomy or conversion or laparoscopic resection with robotic reconstruction, there is now actually a journal article that you can use to determine how to actually name that. So when you're reading other articles, you can compare similar strategies. We also reported on the results of the first international survey on views and experience with minimally invasive pancreatic resection. The next 2 modules on distal pancreatectomy and Whipple focused on perioperative and cancer outcomes, what we knew up to that point. Then we had a module on cost, value, quality of life, which was very, very useful. We really had some nice talks on how to start an MIPR program, how to define value, and then a really nice moving talk by Julie Fleshman, head of the Pancreatic Cancer Action Network, who really addressed the question of what are the patients looking for? Are they calling up PanCan when they have pancreatic cancer diagnosis and saying, who can do my Whipple laparoscopically? Or are they calling up and saying, hey, how can I beat this disease? And at that point, really, it was more the latter. We had a nice session on training and credentialing, and really 2 groups in the world have led this charge. The Pittsburgh group on video assessment and how to train residents, and then the group from the Netherlands really did a nice job describing how you can take the technique and disseminate it to a nation so that you can then move forward with reasonable randomized trials. The last segment was on future research in minimally invasive pancreatic resection. Jeff Barkin led this. He did a very nice job introducing not only should you do randomized controlled trials, but what constitutes a good randomized controlled trial, and then introduce the concept of national and international registries that will be very useful moving forward. All of this was published, 9 different papers in one issue of HPB from March of 2017. You can find these papers online, very useful summaries, and they're actually all quite well written. This is a picture of the organizing committee. I got Ho-Sung Han in the corner here because he wasn't in the picture. I wanted to point out Mark Besselink and his 2 research assistants, Thijs de Rouge and Joni van Hilst, who did a really outstanding job. Thijs is standing behind Horacio Aspan here. And they collected a lot of the data that we used in order to do the data-driven portion of the meeting, so they were invaluable. I would be remiss if I didn't mention Chuck Vollmer, who was my co-chair of this meeting and partner in crime, and we complemented each other's styles quite well as we put this together with a great team. So, for those of you who may be less familiar, what is the ideal framework for surgical innovation? Well, it's really about coming up with a new way of doing something, a new technique in surgery, and then taking it from one end of this diagram to the other, basically from left to right. You have an idea, it's a proof, and you have to come up with some proof that that idea has merit, but then how do you move forward? So in 2009, a paper published in The Lancet by the Ideal Collaboration described these steps more in a concrete manner so that we could follow any new surgical technique and describe it along these steps. So going from proof of concept, which may be case reports, to a development phase where you have case-controlled studies, to an exploration phase where now you're going beyond case-controlled studies, maybe meta-analyses and Cochrane reviews, to the point that you're actually ready to have some appropriate data to then set up a randomized trial to have some idea of what number of patients you need, sample size calculation, et cetera, and ultimately to going back and looking at registries and saying, how's it being done around the world? At the time we held the meeting, we were in the exploration phase of our understanding of minimally invasive pancreatic resection. Where we've gotten to in the past 2 years, if we've begun to scratch the surface in the assessment phase, and really that's where the heart of my talk is going to be, that one move from exploration to assessment. So we'll just give a few slides about some of the background. So Michel Gagné published a paper in 1996. He's an experience with 10 laparoscopic pancreatidoadenectomies, showing his basic outcomes and summarizing and concluding maybe it's not the right thing to do. Subsequent to that, Professor Mabrouk put together a multi-center French study with 122 laparoscopic pancreatic procedures all across the board. Approximately 90% of them were completed successfully, and really what that was proof of concept. It didn't tell us this was the right way to do it. It didn't tell us it was a better way to do it. It just said it could be done. Subsequent to that, I came across this nice paper from Vic Vilanovich. He compared 15 laparoscopic with 15 open distal pancreatectomies. They were sequential, so really not high-level data, but he showed that if he did the procedure laparoscopically, the patient had a little shorter hospital stay, 5 versus 8 days, and similar postoperative pancreatic fistula rates and similar complications. So this paper intrigued me. And around that time, we started seeing larger series of laparoscopic pancreatidoadenectomies, which are shown here, with reasonable conversion, operative times, blood loss, length of stay sort of all over the place, leaks, and mortality rates. So again, more proof of concept, more experience, but larger series, which now help set up the next steps. Then this paper from Mike Kendrick came out, which showed 62 laparoscopic Whipple procedures with very reasonable operative time, very reasonable blood loss, nice nodal harvest, and a length of stay that was extremely reasonable of 7 days. And sort of that opened the door for the next steps. And so we had now truly entered this development phase where we had the ability to do some case control studies because enough people had experience where this could be done. So that's where the Central Pancreas Consortium entered this situation where we decided, instead of each of us reporting on the few 20, 30 cases from our own institution, that we would pool our resources. And this is actually the first paper that our consortium ever put together, which was a multi-center analysis of distal pancreatectomy, and the provocative title, "Should the Laparoscopic Approach Become Standard?" presented at the American Surgical. And this is the key slide. We showed with a matched cohort study, 142 laparoscopic distal pancreatectomies, that the hospital stay was indeed shorter than with open distal pancreatectomy. We went one step further, a more difficult study to do because of low numbers, but a multi-center analysis of distal pancreatectomy laparoscopic for adenocarcinoma. So not only the perioperative outcomes, but the cancer-related outcomes of node harvest, margin, and survival. And we showed that, at least in this experience, that we were able to glean with small numbers from multiple centers over about a decade's time, that the outcomes were pretty much identical. Again, not high-level data, but multi-center data, and well organized. Subsequent to that, there were a host of papers that really looked at comparative analyses. You had this one multi-center paper. You had this next grid were single-center institutions comparing their open and laparoscopic cases. And then we went into the era of large database, national cancer database, the French healthcare database, which further corroborated what we saw in the smaller studies. And then finally a paper on lap Whipple for cancer or not cancer. LPD is lap pancreatic duodenectomy versus open pancreatic duodenectomy, showing pretty much similar operative times, lower blood loss, shorter length of stay, and then in terms of those cancer outcomes, similar node harvest, similar positive margin rates, and likelihood of getting to adjuvant therapy was the same. Subsequent to that, we saw some meta-analyses and some Cochrane reviews, but you know how it goes. If you really don't have high-level data that you put into a meta-analysis or a Cochrane review, you're not going to get earth-shattering results out of them. So this is where we were at the time of the meeting 2 years ago. So now we're setting the stage for what has come since. And entering this phase, what I didn't mention were there were a few other meetings about minimally invasive pancreatic resection all around the same time. They were fairly clustered. There was the EAES Consensus Conference. So although we decided that maybe it wasn't the right time to have true consensus, a group of experts in Europe did come together. They created some statements from experts in a multi-step process. They had a face-to-face meeting. They modified the statements. They then posted them. They presented them at the EAS in 2016. And then they posted them online for further input and finally additional modification. And that is published in Surgical Endoscopy of 2017. In Coimbatore, India, there was another international summit on laparoscopic pancreatic resection. I had the pleasure of participating, and it was more technique-focused, and the outcomes and summaries from that are also published, and they are in Surgical Oncology from 2018. And then after that, in Yokohama, there was another consensus meeting, which has put forth 2 publications, which are shown here, and this was at the HPBA. So let's get to the randomized trials, and so that we have some information for the next meeting. So I invited Yoni Van Hilst to come to Seattle at the SSAT this year to give a summary on the randomized trials in minimally invasive pancreatic resection. She did a wonderful job with her talk, and I benefited by taking some of her slides. Here we see the 13 trials that were registered through the WHO registry. There are 13 that are listed, 6 for distal, 6 for Whipple, and 1 for middle pancreatectomy. And 3 of them were closed or withdrawn and never resulted. There are 4 that have resulted, and 1 additional one that is accruing that I'm going to discuss today. And these are the 5 trials that are shown right here. 2 for distal pancreatectomy and 3 for Whipple. This map just shows where those trials originated in a high cluster here in Europe. So of the 6 randomized controlled trials for minimally invasive distal pancreatectomy, 2 closed early. We have 1 that has resulted and is published, was presented at the AHPBA last year in Miami, and we'll also discuss what's going on with the diploma trial, and that one that is actively recruiting. And I think it's a European trial, but I think the first patient was just accrued in the United States. So we're trying to move this to transcontinental. And then the Swedish trial, the POP, I was not able to find any data on this, so by all means, at the end of the talk, if somebody has some information and can enlighten us on where that trial is. The Leopard trial. This is the trial that was published in Annals of Surgery. The senior author is Mark Besselink, and here's Thijs de Rouge, who worked very diligently on this project. Randomized trial across the Netherlands, primary endpoint, minimally invasive versus open distal pancreatectomy, and the primary endpoint was time to functional recovery after surgery. And what time to functional recovery means is listed right below. Independent mobility, adequate pain control, the patient can maintain greater than 50% of daily required caloric intake, no requirement for intravenous fluid administration, and no signs of infection. And the patients were blinded as to which operation that they had. And so you may ask, for those of you who don't know about this trial, how you blind a patient to what operation they've had. That's how, a very large abdominal dressing. The clinical team obviously knew, because they knew if they had to be aware of a different concern. But the patients, I guess, in the Netherlands are more, they probably take direction better than they would in the United States, but this is what they did. And I had the pleasure of going over and actually seeing some of these patients when I visited AMC. Here are the results from the study as published. They had 51 minimally invasive distal pancreatectomy compared with 56 open distal pancreatectomy. And the first outcome, the time to functional recovery, was deemed 4 days for minimally invasive as compared with 6 days for open. There was a higher rate, actually, of postoperative pancreatic fistula in the minimally invasive group, which approached significance, as you can see, 39% versus 23%. And then the length of stay was 2 days shorter for minimally invasive distal pancreatectomy. So the conclusion from this study was that minimally invasive distal pancreatectomy compared with open distal pancreatectomy was associated with a 2-day reduction in time to functional recovery, the primary endpoint. And they ended with saying that minimally invasive distal pancreatectomy is the treatment of choice for patients with left-sided pancreatic tumors. So what's come next? Well, I guess you could say the question's been answered, is it appropriate to do a distal pancreatectomy laparoscopically? I think probably the answer is yes. I think there still are some regional differences in patients, so it may not be enough to say that trial answers the question definitively. But this group is now moving on to the next question, and that is, should we really be doing these for adenocarcinoma? We have retrospective comparative data, but this is now prospective. 5 years ago, if you had asked me, I didn't think that this could possibly be done, because the number of left-sided distal pancreatectomies for adenocarcinoma that are performed, at least in the United States, it would take years and years to accrue enough patients to be able to answer this question. So this is being taken to an international effort. So first, what the team did in the Netherlands and then across Europe was band together to first do a retrospective cohort analysis. I guess this was proof of principle to see whether everybody could work together towards this end. They combined data from 34 centers, over 1,000 patients, and then they did a propensity score matched analysis for minimally invasive distal pancreatectomy and open, specifically for pancreatic ductal cancer. And here are the outcomes. Lower blood loss for the laparoscopic or minimally invasive approach. Otherwise, a similar percentage of multivisceral resection, adjuvant chemotherapy, overall survival, no different. There was a higher R0 rate in the minimally invasive approach, but interestingly, there was a higher node harvest with the open approach, which is a bit conflicting, but at the same time, it is what it is, and these are what the data show from this study. So then the next step was to set up the randomized controlled trial. This group has met several times. The trial is open. I think 17 centers now are open to accrual. And as I mentioned, the first patient has been accrued in the United States, in Seattle. And this is distal pancreatectomy, randomized controlled trial, minimally invasive or open for malignancy. The primary outcome is radical resection margins, and busy slide showing the centers that are involved. It's now up to 40 centers with 17 open to accrual. So we will await and we will contribute to this trial as well. So what about for Whipple? We have 6 randomized controlled trials that have been started, 1 withdrawn. We have 3 that have resulted. We have the plot trial from India. We have the Padulap trial from Barcelona. And then we have the Leopard 2 trial that was recently presented at the Pancreas Club. So those are the 3 we're going to focus on. So the plot trial, single center trial from Coimbatore. It is the pancreatic head and periampullary cancer laparoscopic versus open treatment trial. It was recorded 2 years ago, presented at the IHPBA in Sao Paulo, and it's published in the British Journal of Surgery. It's a small study, but the first one of its kind. Laparoscopic, 32 cases versus open. This is straight laparoscopic, no robots. And the main outcome of interest is the shorter hospital stay. 7 days versus 13 days with a significant p-value. Not a major difference in major complications, delayed gastric emptying, fistula rates, and significant fistulas. Subsequent and most recently, the Padulap trial is now online in Annals of Surgery. This is the trial from Professor Povis in Barcelona. Again, similar number of patients, single center, 32 patients who had lap Whipple versus 29 patients who had open Whipple. Here, the primary outcome of interest was significant complications. There were fewer significant complications in the laparoscopic group, 15% versus 38%. Length of stay at the bottom, as you see, was also shorter for the laparoscopic cohort at 13.5 days versus 17 days. Significant p-value. Okay, so now we've answered the question. A laparoscopic Whipple is better than an open Whipple. Well, maybe not. And so this is the question that we have to keep moving forward with. The Leopard 2 trial, which is out of the Netherlands as well, it is a multi-center, 4-center phase 2-3 multi-center trial of laparoscopic versus open pancreatoduodenectomy. Each group had to have performed at least 20 Whipples per year, and each group had to have performed at least 20 laparoscopic pancreatoduodenectomy before being allowed to participate in the trial. They had to undergo specific LPD training. The primary endpoint, again, was time to functional recovery, and additional outcomes or endpoints were grade 3 complications, significant postoperative pancreatic fistula, length of stay, and quality of life. Well, the trial was supposed to accrue close to 140 patients, and it was stopped by the Data Safety Monitoring Board at 99 patients because of a difference in mortality, 2% for the open cohort versus 10% for the laparoscopic cohort. The time to functional recovery was actually higher in the laparoscopic cohort, 10 days versus 8 days. And the conclusion from this trial is that laparoscopic pancreatoduodenectomy as compared with open was not associated with improved time to functional recovery, but with a safety concern for complication-related mortality. This is a published abstract online. This paper is in submission right now. So if we summarize the existing resulted randomized controlled trials for laparoscopic Whipple, we see two small single-center randomized controlled trials supporting a shorter length of stay for lap versus open Whipple. And then we see one larger multi-center RCT that was stopped early due to increased patient mortality for LPD versus OPD. So I would say at this point, there are some folks out there doing it well, but I think we have to interpret the data with some caution, and I think the jury is still out on whether lap Whipple is really an approach that should be adapted by everyone. So I haven't mentioned robot very much. There really has not been any randomized controlled trial looking at robot. We did do a multi-center study comparing open and robotic Whipple through the Central Pancreas Consortium. This is a retrospective study. Two centers performed the robotics, the Pittsburgh and the Cleveland Clinic groups. The rest were performing the open procedure. Everybody who participated in this had to have done at least 200 Whipples, and the minimally invasive group had to have completed at least 80 Whipples to contribute their cases robotically in order to do a comparison. So this is post-learning curve data. And if you look at this set up a little bit differently in the title, we have open and robotic. And in the open, 817 cases versus robotic 211. There was indeed a shorter operative time for the open approach. In terms of blood loss, there was lower blood loss for the robotic approach, but no meaningful increase in transfusion for the open approach. And then the fistula rate, slightly lower, but not statistically significant on multivariable analysis for in favor of the open approach. No significant difference in significant complications, and the hospital length of stay was 8 days for both groups. And part of our conclusion in this manuscript is a lot of that is more about having an enhanced recovery process rather than the approach. The mortality was low in both groups. There have been a couple meta-analyses looking at robotic and laparoscopic distal pancreatectomy. This one is the largest, 9 studies, 637 patients. About half performed robotic, a little bit more done laparoscopic. Showed a longer operative time for robotics, a shorter hospital stay for robotics, but a higher readmission rate. So I think when we see shorter stays, in general, we probably see higher readmissions. Ultimately, the conclusion was, can't really tell that there's much of a difference yet. So I think this is the phase that we're in for the ideal, with regards to the ideal framework in terms of minimally invasive pancreatic resection. And we still need to go through a little bit more, some more iterations before we can get to this last step. And to get there, we'll probably need additional multi-center, multinational randomized trials and development of international registries. I'm going to make one plug on behalf of Horacio Aspun and his organizing committee. In March of 2019, there is going to be an international evidence-based guidelines conference on minimally invasive pancreatic resection. It'll be in Miami the same week as the AHPBA. So I have planned everybody's week for you in March of next year. You're going to arrive in Miami on March 17th. You'll go to the minimally invasive pancreatectomy meeting on Monday and Tuesday. There'll be a transition day on Wednesday where you'll be able to watch live surgery, and then you'll enjoy the AHPBA from Thursday to Sunday. Thank you very much, and I'm happy to answer any questions.